Advances in obstetric and neonatal care have dramatically improved survival of high-risk neonates. Yet this success has not resulted in decreased morbidity. As total numbers of survivors at risk for neurodevelopmental problems increase, the absolute number of both healthy and neurologically impaired survivors has grown. Since the 1960s, mortality continues to decline, while survival of increasingly immature infants results in relatively high disability rates, particularly among those born weighing less than 750 grams or before 26 weeks gestation. Long-term follow-up becomes essential because perinatal interventions that demonstrate immediate positive effects may carry adverse long-term consequences. Therapies like oxygen administration and postnatal steroids that initially appear beneficial can later reveal unexpected neurodevelopmental sequelae. The goals of effective follow-up programs include early identification of neurosensory or developmental disability, comprehensive parental counseling, identification and treatment of ongoing medical complications, evaluation of therapeutic interventions, and providing crucial feedback to perinatal and pediatric caregivers. This systematic approach ensures that life-saving NICU interventions truly benefit long-term outcomes, rather than simply shifting morbidity to later developmental stages. Follow-up programs traditionally target infants with birth weights less than 1,500 grams or gestational ages below 32 weeks as primary candidates for intensive monitoring. However, the highest-risk subgroup requires special attention: those born weighing less than 750 grams or before 26 weeks gestation, who face dramatically elevated rates of neurodevelopmental sequelae. Multiple perinatal factors amplify risk beyond gestational age and birth weight alone. Severe asphyxia, grade 3 or 4 intraventricular hemorrhage, periventricular leukomalacia, meningitis, neonatal seizures, and bronchopulmonary dysplasia all significantly increase vulnerability to long-term complications. Environmental factors compound these biological risks, with poverty, parental substance abuse, and limited social support creating additional barriers to optimal development. Modern therapies have expanded the need for specialized follow-up beyond traditional preterm populations. Inhaled nitric oxide and extracorporeal membrane oxygenation have increased demand for highly specialized clinics serving term infants with persistent pulmonary hypertension, meconium aspiration, and sepsis. Additionally, growing numbers of infants with major congenital malformations now survive the neonatal period requiring intensive ongoing support, fundamentally changing the landscape of high-risk follow-up care. Population-based data from the EpiPage 2 cohort clearly demonstrate the inverse relationship between gestational age and neurodevelopmental risk. Infants born at 24 to 26 weeks face the highest burden, with cerebral palsy rates approaching 8% and neurodevelopmental delay affecting approximately 52% of survivors at 2 years of age. This represents a substantial improvement from earlier eras, yet remains significantly elevated. The 27 to 31-week gestational age group shows markedly improved outcomes, with cerebral palsy rates declining to roughly 4% and neurodevelopmental delay affecting 41% of children. By 32 to 34 weeks gestation, risks decrease further to about 1% for cerebral palsy and 37% for neurodevelopmental delay, though these rates still exceed those of term infants. Small for gestational age status compounds risk across all gestational age categories. These growth-restricted infants demonstrate higher rates of both motor and cognitive impairments, likely reflecting the cumulative impact of intrauterine stress and compromised fetal development. The data emphasize that while survival has improved dramatically across gestational ages, substantial neurodevelopmental morbidity persists, particularly among the most immature survivors. These statistics provide essential counseling information for families and guide resource allocation for long-term developmental services. Transient neurologic abnormalities occur in 20 to 40% of high-risk infants, with peak incidence of transient dystonia at 7 months corrected age. These early findings include hypertonia manifesting as poor head control at 40 weeks post-conceptional age, inadequate back support at 4 to 8 months, and slight increases in upper extremity muscle tone. While concerning to families, these abnormalities typically resolve by the second year of life. However, clinical vigilance remains crucial because children destined to develop cerebral palsy often initially present with hypotonia and only later develop characteristic spasticity. The transition from hypotonia to spasticity during the first 3 to 4 months represents a poor prognostic sign. Physiologic hypertonia normally exists during the first 3 months, making early diagnosis of pathologic spasticity challenging. The critical time point occurs around 8 months corrected age. Mild hypotonia or hypertonia persisting beyond this threshold may indicate developing cerebral palsy or later subtle neurologic dysfunction. Persistence of primitive reflexes provides additional warning signs. Environmental factors increasingly influence functional assessment as children mature, with maternal education and social class beginning to modulate cognitive outcome measures during the second year. Early recognition enables prompt therapeutic intervention during periods of maximal neuroplasticity. Major neurologic sequelae typically emerge during the latter part of the first year and encompass several distinct categories. Cerebral palsy dominates the landscape, with spastic forms accounting for approximately 85% of all cases and over 90% of preterm-related cerebral palsy. Diplegia and hemiplegia represent the most common subtypes, characterized by increased tone with velocity-dependent resistance to passive movement, pathologic reflexes including hyperreflexia and Babinski responses, and abnormal movement patterns. Spastic diplegia primarily affects lower extremities with equinus foot positioning, crouch gait, internal rotation, and hip adduction. Upper limb involvement includes arm flexion, fisted hands, adducted thumbs, and poorly coordinated finger movements. Children with quadriplegia typically demonstrate severe developmental delay, while those with diplegia or hemiplegia may maintain better cognitive function. Hydrocephalus frequently accompanies cerebral palsy or occurs independently, requiring ongoing neurosurgical management. Intellectual disability ranges from mild to severe, with outcomes varying significantly by neurologic diagnosis. Sensory impairments include blindness, primarily from retinopathy of prematurity, and sensorineural hearing loss. Minor motor disorders affecting pencil manipulation, bicycle riding, and daily motor tasks occur more frequently than major disabilities, impacting approximately 1/3 of preterm children, yet often receiving insufficient recognition in clinical assessment protocols. Strategic timing of follow-up visits maximizes detection of evolving problems while minimizing family burden and healthcare costs. The initial visit occurs shortly after NICU discharge, serving the crucial purpose of evaluating home adaptation and addressing practical concerns, including medication accuracy, oxygen administration, formula preparation, and emerging parental anxieties about their infant's ongoing care needs. The 4 to 6 month corrected age visit targets documentation of growth problems and emerging neurologic abnormalities. By this time point, many active medical issues have resolved, creating opportunities to redirect family attention toward developmental and behavioral concerns. This visit proves particularly valuable for identifying infants requiring intervention or occupational and physical therapy. 8 to 12 months corrected age represents the optimal window for identifying cerebral palsy or other neurologic abnormalities. Children demonstrate minimal stranger anxiety at this age while maintaining cooperative behavior, making this the ideal time for the first formal developmental assessment using the Bayley scales of infant development. Although behavioral patterns begin establishing during this period, early cognitive skills remain heavily dependent on motor function. By 18 to 24 months corrected age, most transient neurologic findings resolve, and neurologically abnormal children demonstrate adaptive improvements with better functional abilities. Environmental factors increasingly influence functional assessment, while cognitive and language scales provide assessment independent of motor development. School-age follow-up becomes essential for detecting subtle neurologic dysfunction and academic performance issues that may not manifest until complex cognitive demands emerge. The medical home concept integrates primary care with specialized neurodevelopmental follow-up, creating comprehensive care coordination for children with sequelae of prematurity. This model addresses the complex reality that these vulnerable infants require both routine pediatric care and specialized monitoring for neurodevelopmental complications, extending well beyond neonatal intensive care unit discharge. Initial neonatologist involvement provides essential family reassurance during the critical transition period. Parents derive significant psychological benefit from knowing that the same medical personnel responsible for life-saving NICU decisions continue assuming responsibility for their child's adaptation to home life. This continuity builds trust and confidence during the vulnerable early months when families face ongoing medical uncertainties and complex care requirements. Comprehensive multidisciplinary clinics have demonstrated improved outcomes at reduced costs compared to fragmented care models. These clinics coordinate multiple specialty services within single visits, reducing family burden while ensuring comprehensive assessment of growth, neurologic development, psychomotor and cognitive function, vision, and hearing. As trust and familiarity develop, care gradually transitions to the general pediatrician, though subspecialist involvement continues as needed. Neonatal care providers benefit equally from follow-up involvement by maintaining contact with former patients and observing long-term consequences of prematurity and neonatal interventions. This feedback loop proves invaluable for improving NICU practices and understanding the true impact of early therapeutic decisions on developmental outcomes throughout childhood. The Bayley Scales of Infant Development serves as the most commonly used tool for monitoring early cognitive and motor development in high-risk infants, spanning ages 1 month to 3.5 years. During the past 25 years, longitudinal follow-up programs have relied on this assessment for both research outcomes and clinical identification of infants requiring interventional services. Understanding the evolution of Bayley editions proves critical for interpreting results. The first and second editions provided mental developmental index and psychomotor developmental index scores with means of 100 and standard deviations of 15. The 2006 third edition expanded to 5 scales, including cognitive, language, motor, social-emotional, and adaptive behavior components, with the latter two assessed through parent questionnaires rather than generating traditional developmental indices. Optimal testing occurs at 8 to 12 months when children demonstrate minimal stranger anxiety and maximum cooperation, though early cognitive skills remain heavily dependent on motor function. The 18 to 24-month assessment provides more motor-independent cognitive evaluation, offering clearer separation between intellectual and physical capabilities. However, a critical limitation emerges. Infant tests describe current functioning rather than predicting future intelligence, showing poor, long-term predictive validity, especially for clinical subgroups. The Bayley III controversy centers on score inflation compared to earlier editions, with cognitive scores averaging 6 to 10 points higher and motor scores 8 to 14 points higher than comparable Bayley II results. This apparent improvement may reflect under-identification of neurodevelopmental impairment rather than true outcome enhancement, raising concerns about accurate diagnosis and early intervention referrals. Age-appropriate assessment tools become increasingly sophisticated as children mature, reflecting the expanding complexity of cognitive, behavioral, and academic skills that require evaluation. Preschool assessment utilizes specialized instruments, including the Wechsler Preschool and Primary Scale and Kaufman Assessment Battery, which provide more detailed cognitive evaluation than possible during infancy while accounting for developmental variability typical of this age group. School-age assessment relies heavily on the Wechsler Intelligence Scale for children as the most commonly used comprehensive cognitive evaluation tool. By ages 7 to 9 years, assessment capabilities expand dramatically to include subtle neurologic dysfunction, behavioral problems, and academic performance measures that reveal learning disabilities and attention difficulties not apparent during earlier developmental periods. Screening tools serve complementary roles in ongoing surveillance. The Ages and Stages questionnaire provides efficient monitoring from 3 months through 5 years, enabling early identification of children requiring more comprehensive evaluation. Parent and teacher questionnaires become increasingly valuable as children enter educational settings where behavioral and learning difficulties manifest most clearly. Behavioral assessment batteries, including the behavior rating, inventory of executive function, Developmental Neuropsychological Assessment, ADHD rating scales, and Woodcock-Johnson 3 provides specialized evaluation of executive function, attention, and academic achievement. These tools prove essential for identifying the subtle cognitive and behavioral sequelae that commonly affect preterm survivors, but may not emerge until school-age academic demands reveal underlying processing difficulties, learning disabilities, and attention problems that significantly impact educational success and long-term functional outcomes. Environmental factors profoundly influence brain development in preterm infants, with NICU stress demonstrating measurable associations with altered brain maturation patterns. Research reveals that the intensive care environment itself, while life-saving, creates stressors that impact developing neural circuits and long-term neurodevelopmental outcomes in ways we are only beginning to understand. Procedural pain emerges as a particularly significant factor, with studies demonstrating that higher numbers of painful procedures correlate with delayed white matter maturation and adverse cognitive outcomes extending into early childhood. This relationship proves dose-dependent, with cumulative pain exposure predicting cortical thickness changes at age 7 years and affecting corticospinal tract development in measurable ways that persist well beyond the NICU stay. The score for neonatal acute physiology 2 and neonatal pain exposure together predict corticospinal tract development in premature newborns, highlighting the complex interplay between illness severity and procedural stress. Neonatal pain also relates to slower postnatal growth, which itself serves as a predictor of delayed cerebral cortical maturation, creating cascading effects on brain development. Long-term impacts extend to school age, where invasive procedures during the preterm period affect brain structure and cognitive development in measurable ways. However, protective factors exist. Parent behaviors can moderate the relationship between neonatal pain and internalizing behaviors at 18 months corrected age. Maternal stress and behavior patterns, parenting stress, and parent-infant interactions all influence how neonatal experiences translate into developmental outcomes, emphasizing that optimal parent-child relationships can partially compensate for early adversity and promote resilience despite challenging NICU beginnings. Neurodevelopmental care represents a fundamental paradigm shift, recognizing preterm infants as developing humans with unique neurobiological vulnerabilities and inherent capacities for self-regulation. This approach moves beyond traditional medical stabilization to support organized behavioral state regulation and optimal neurobehavioral development during the critical period of brain maturation that occurs ex utero. Research demonstrates that NICU stress significantly impacts brain development in preterm infants, with higher numbers of painful procedures correlating with delayed white matter maturation and adverse cognitive outcomes extending into early childhood. The score for neonatal acute physiology 2, combined with neonatal pain exposure, predicts corticospinal tract development, highlighting how environmental factors profoundly influence emerging neural circuits. Family-centered, individualized care protocols recognize that each infant demonstrates unique behavioral cues, indicating stress, stability, and readiness for interaction. This approach respects the infant's emerging autonomy while providing appropriate environmental support to promote self-regulation capabilities. Key components of early intervention programs demonstrate that parent behaviors can moderate the relationship between neonatal pain and internalizing behaviors at 18 months corrected age. The evidence supports that optimal parent-child interactions during NICU hospitalization serve protective functions, potentially compensating for early brain maturation disruptions. Maternal stress and behavior patterns significantly influence how neonatal experiences translate into developmental outcomes, emphasizing that quality caregiving relationships can promote resilience despite challenging beginnings in the intensive care environment. Environmental modifications target specific sensory systems to optimize brain development during the vulnerable preterm period when rapid neuronal connectivity and myelination occur. Light management involves implementing diurnal cycling to support circadian rhythm development, while reducing bright procedural lighting that can disrupt developing retinal structures and interfere with sleep-wake cycling patterns essential for brain maturation. Sound reduction protocols target baseline levels below 45 decibels, recognizing that excessive noise exposure correlates with altered brain development and stress responses. Sudden loud noises and frequent alarm sounds can disrupt the delicate balance of developing auditory pathways and compromise the infant's ability to achieve organized sleep states critical for neural development. Touch modifications emphasize gentle, purposeful contact while avoiding disruption of sleep cycles, which research shows are essential for brain development and recovery. Studies demonstrate that invasive procedures during the preterm period affect brain structure and cognitive development at school age, making thoughtful touch protocols crucial for neuroprotection. Temperature stability through neutral thermal environments prevents the metabolic stress associated with thermoregulation, allowing energy resources to support brain growth rather than compensatory mechanisms. Space organization creates quiet, protective environments that minimize visual overstimulation while supporting the infant's emerging capacity for environmental interaction. These modifications collectively reduce NICU stress, which research associates with altered brain development patterns and long-term neurodevelopmental outcomes. Optimal positioning strategies support physiologic development by promoting flexed postures that mirror intrauterine positioning and facilitate self-regulation capabilities. Flexed positioning maintains the natural muscle tone patterns necessary for proper skeletal development, while supporting the infant's emerging motor control and postural stability. This positioning reduces energy expenditure associated with maintaining anti-gravity postures, allowing metabolic resources to support critical brain development processes. Midline orientation facilitates hands-to-face and hands-to-mouth activities that promote sensory integration and early self-soothing behaviors. These movements support the development of coordinated motor patterns while providing proprioceptive feedback essential for body awareness and spatial orientation. Research demonstrates that normal full-term infants exhibit active movement of flexed limbs with specific hip and knee positioning that should be supported in preterm infants. Boundary support through appropriate positioning aids provides containment and security that mimics the intrauterine environment while preventing the stress responses associated with uncontrolled movements in an open environment. This support promotes organized behavioral states and reduces excessive energy expenditure that could compromise growth and development. Prevention of equipment-induced positioning problems protects against developmental deformities that can arise from prolonged static positioning or inappropriate support surfaces. Careful attention to head positioning, particularly elevated midline positioning, has demonstrated protective effects against periventricular intraventricular hemorrhage while supporting optimal cerebral perfusion. These positioning strategies collectively support both immediate physiologic stability and long-term developmental outcomes. Cue-based care represents a sophisticated approach to infant interaction that requires systematic assessment of behavioral signals indicating stress, stability, and readiness for intervention. Research demonstrates that preterm infants demonstrate specific behavioral cues reflecting their neurologic integrity and developmental capacity, making skilled observation essential for appropriate care. Timing and intensity. Assessment of behavioral cues involves monitoring autonomic stability, motor organization, and state regulation before, during, and after all care activities. These observations guide decision-making about intervention timing and intensity, recognizing that poorly timed care can disrupt fragile physiologic systems and compromise developmental progress. Studies show that maternal stress and behavior patterns can modulate the relationship between neonatal stress and developmental outcomes. Respecting sleep-wake cycles becomes crucial, given research showing that sleep-wake cycling quality and timing reflect the severity of brain injury and predict neurodevelopmental outcomes. Recovery of organized sleep-wake cycling within appropriate timeframes indicates improving neurologic function, while disrupted patterns suggest ongoing compromise requiring modified care approaches. Clustered care protocols group necessary procedures to maximize uninterrupted rest periods essential for brain development and recovery. Evidence demonstrates that procedural pain relates to slower postnatal growth and delayed cerebral cortical maturation, making recovery time between interventions critical for physiologic stabilization. Minimizing unnecessary handling reduces cumulative stress exposure that research links to altered brain maturation patterns. This systematic approach supports the infant's emerging capacity for self-regulation while protecting vulnerable developmental processes. Pain management in neonates extends beyond humanitarian concerns to represent a critical neuroprotective intervention. Research demonstrates that procedural pain predicts cortical thickness changes at age 7 years and affects corticospinal tract development in measurable ways that persist well beyond NICU discharge. Higher numbers of painful procedures correlate directly with delayed white matter maturation and adverse cognitive outcomes extending into early childhood. Assessment tools including validated neonatal pain scales such as PIP, CRIES, and NPAS provide systematic approaches to pain recognition in populations with limited behavioral repertoires for pain expression. These tools account for gestational age, physiologic parameters, and behavioral indicators to generate reliable pain scores, guiding appropriate interventions. Pharmacologic approaches require careful consideration of analgesic selection, dosing, and timing to provide effective pain relief while minimizing potential adverse effects on developing organ systems. Research demonstrates that certain analgesic medications can impact specific brain regions, with morphine exposure predicting slower cerebellar growth and midazolam affecting hippocampal development. Non-pharmacologic comfort measures, including sucrose administration, skin-to-skin contact, and non-nutritive sucking, provide effective pain relief for minor procedures while supporting parent-infant bonding and physiologic stability. These interventions work synergistically with pharmacologic approaches to optimize comfort while supporting developmental processes. Long-term brain protection represents the ultimate goal, recognizing that unmanaged pain affects brain development trajectories and functional outcomes. Studies confirm that parent behaviors can moderate relationships between neonatal pain and later behavioral outcomes, emphasizing the importance of comprehensive pain management strategies that include family education and support. Family integration transforms traditional medical care models by recognizing parents as essential partners in neurodevelopmental support rather than passive observers of medical interventions. Research demonstrates that key components of early intervention programs include parent education and support, with evidence showing that parent behaviors can moderate the relationship between neonatal stress and developmental outcomes. Skin-to-skin care provides multiple physiologic and developmental benefits, including improved behavioral state regulation, enhanced bonding opportunities, support for breastfeeding initiation, and promotion of optimal growth patterns. Studies demonstrate that variations in postnatal maternal care influence epigenetic regulation of neurotransmitter systems and hippocampal function, highlighting the biological mechanisms through which parent-infant interactions influence brain development. Parent education focuses on teaching families to recognize and respond appropriately to infant behavioral cues, supporting the development of sensitive, responsive caregiving relationships. This education includes recognition of stress signals, comfort measures, and techniques for supporting infant self-regulation. Research shows that parent-child interaction quality correlates with cognitive function in preterm infants, emphasizing the importance of skilled parent-infant interactions. Active participation enables parents to assume primary caregiving roles gradually while maintaining appropriate medical support and supervision. This approach builds parental confidence and competence while supporting attachment formation during a critical developmental period. Evidence demonstrates that maternal stress and behavior patterns modulate relationships between neonatal stress and later attention and cortisol regulation, making family support and education essential components of comprehensive neurodevelopmental care programs promoting optimal long-term outcomes. Sleep protection forms a cornerstone of neuroprotective NICU care, with direct implications for neurodevelopmental outcomes. Research demonstrates that sleep-wake cycling recovery serves as a powerful prognostic indicator. Return of normal cycling before 36 hours correlates with favorable outcomes, while delayed recovery beyond 36 hours predicts adverse neurodevelopmental sequelae. Protecting infant sleep involves strategic timing of necessary interventions during natural alert periods rather than disrupting quiet sleep states. Preterm infants demonstrate distinct EEG patterns during different sleep phases. Quiet sleep shows discontinuous trace-A alternate patterns, while active sleep displays mixed delta-theta activity. These patterns mature predictably, and disruption during critical developmental windows can impair normal brain maturation. Circadian rhythm development depends on appropriate light-dark cycles when medically feasible. However, clinical priorities always supersede circadian considerations. Quiet hours implementation reduces unnecessary stimulation while maintaining essential monitoring. State-based care timing optimizes interventions by recognizing when infants are naturally more receptive to handling and procedures. The relationship between sleep quality and neurodevelopmental outcomes extends beyond immediate NICU care. Establishing healthy sleep patterns supports ongoing brain development and prepares families for home care transitions. Effective sleep protection requires balancing medical necessities with developmental needs through individualized assessment of each infant's sleep-wake patterns and stress responses. Feeding success in NICU graduates directly correlates with neurodevelopmental outcomes and long-term growth trajectories. Preterm infants frequently demonstrate incoordination in suck-swallow-breathe patterns, accompanied by hyperactive gag reflexes that can precipitate apnea and aspiration events. These feeding challenges often persist beyond initial hospitalization, requiring ongoing therapeutic intervention. Breastfeeding support takes priority when infants achieve medical stability, as breast milk provides optimal nutrition and immunologic benefits. However, feeding progression must prioritize safety. Aspiration risk assessment guides timing of oral feeding attempts. Non-nutritive sucking opportunities support oral motor development and provide self-regulation benefits, even when infants aren't ready for nutritive feeds. Recognition of feeding cues becomes crucial as infants mature neurologically. Hunger signals include rooting, hand-to-mouth movements, and increased alertness, while satiety cues manifest as turning away, pushing away the bottle, or falling asleep. Responding appropriately to these cues promotes healthy feeding relationships and prevents overfeeding. Bulbar weakness, commonly seen in conditions like spinal muscular atrophy or myasthenia gravis, severely compromises feeding safety. These infants often require tube feeding to ensure adequate nutrition while protecting against aspiration. Speech therapy evaluation guides safe progression of oral motor skills, with swallowing studies determining appropriate feeding modifications and timing for oral feeding advancement. Early intervention during NICU hospitalization establishes the foundation for optimal long-term outcomes in high-risk infants. Research from the Infant Health and Development Program demonstrates that comprehensive interventions improve cognitive outcomes at 3 years, though effects may diminish over time without continued support. Physical therapy addresses positioning needs, promotes motor development, and maintains range of motion to prevent contractures. Proper positioning supports optimal lung function while promoting normal movement patterns. Occupational therapy focuses on feeding skills, sensory processing abilities, and activities of daily living, crucial foundations for independence as children mature. Speech therapy evaluation becomes essential for infants with swallowing difficulties, communication delays, or oral motor impairments. Early identification of communication needs allows for intervention strategies that support language development from the earliest stages. These services must begin during hospitalization rather than waiting for discharge. Integration across disciplines prevents fragmented care and ensures consistent therapeutic approaches. Parent education represents the most critical intervention component. Families learn to recognize developmental cues, provide appropriate stimulation, and continue therapeutic strategies at home. This education must emphasize relationship building and attachment formation alongside specific developmental techniques. Evidence suggests that longer, more intensive community-based interventions yield better kindergarten readiness outcomes, highlighting the importance of seamless transition from NICU-based services to community resources for continued developmental support. Systematic neurodevelopmental monitoring requires structured approaches, combining clinical observation with standardized assessments. Daily behavioral observations document self-regulation abilities, stress responses, and emerging developmental milestones. These observations guide real-time care modifications and inform discharge planning. Regular neurologic examinations assess tone, reflexes, and movement patterns using standardized tools like the Amiel-Tison neurologic assessment. This examination measures progressive increases in active muscle tone alongside decreasing passive tone, providing qualitative assessment of neurologic integrity. The Preterm General Movement Assessment demonstrates particular value for early identification of infants at risk for cerebral palsy. The Bayley scales of infant development serves as the gold standard for monitoring cognitive and motor development in high-risk populations. Timing of assessments matters. 8 to 12 months corrected age provides optimal cooperation while allowing meaningful cognitive assessment independent of motor function. By 18 to 24 months, most transient neurologic findings resolve, revealing true developmental trajectory. Family involvement transforms monitoring from purely clinical assessment to comprehensive developmental support. Parental observations provide critical insights into daily functioning and behavioral patterns that clinical encounters might miss. Including family concerns in assessment planning ensures culturally responsive care and builds parental confidence in recognizing developmental progress. Individualized care plan adjustments based on ongoing assessments prevent developmental delays from becoming entrenched. This requires systematic data collection, regular interdisciplinary team communication, and flexibility in therapeutic approaches based on infant responses and family needs. Early neurologic assessment forms the foundation of developmental monitoring in high-risk infants, with two evidence-based methods providing crucial prognostic information. The Amiel-Tison method represents a systematic approach that captures the fundamental neurodevelopmental principle underlying infant neurologic maturation. The Amiel-Tison examination measures the progressive increase in active muscle tone alongside the concomitant decrease in passive tone. This dual pattern reflects normal neurologic development. The assessment systematically evaluates head control, back support, sitting, standing, and walking progression, while also documenting visual and auditory responses, plus primitive reflexes. This comprehensive approach provides qualitative assessment of neurologic integrity, categorized as normal, suspect, or abnormal. General movements triggered by the neonatal nervous system arise from central pattern generators located in the neonatal brainstem, normally lending variability to motor output. Reduced modulation of these generators results in less variable movements, potentially indicating fetal or neonatal compromise. The Preterm General Movement Assessment demonstrates particular clinical value, with systematic review evidence confirming it as the most sensitive and specific test available for early prediction of spastic cerebral palsy in high-risk infants. This assessment evaluates the quality and variability of spontaneous movements, providing crucial early prognostic information that guides intervention planning and family counseling during the critical early months when other assessments may be less reliable. The Gross Motor Function Classification System revolutionized cerebral palsy assessment by shifting focus from deficits to functional capabilities in real-world settings. Introduced by Palsy, GMFCS provides standardized classification of gross motor function using a 5-level system that emphasizes practical daily living skills rather than clinical capabilities. GMFCS defines motor function according to self-initiated movement, with particular emphasis on sitting, walking, and mobility skills that directly impact independence. The classification criteria focus on functional limitations, the need for assistive devices such as walkers, crutches, or wheeled mobility, and considers quality of movement to a lesser extent. The system's strength lies in its emphasis on usual performance in home, school, and community settings, rather than optimal clinic-based performance. This approach provides more meaningful information for families and educators about what children can actually accomplish in their daily environments. Age-dependent classifications ensure developmental appropriateness, with separate descriptions applied across various age ranges. The focus remains on determining which level best represents the child's present abilities and limitations, supporting realistic goal setting and intervention planning. GMFCS proves particularly valuable for children with cerebral palsy, where traditional assessment methods might focus on impairments rather than functional capacity. By emphasizing what children can do as their best capability, this system supports more positive, strength-based approaches to intervention and educational planning. The GMFCS flowchart provides a systematic decision tree for determining functional motor classification, beginning with the highest level of function and proceeding through increasingly supportive needs. This hierarchical approach ensures accurate classification while highlighting functional progression patterns. Normal classification requires independent walking of 10 or more steps with symmetrical gait, representing the developmental goal for motor function. Level 1 children demonstrate independent sitting with hands free for play and can creep or crawl, but cannot achieve independent walking, indicating mild motor limitations with good potential for mobility aids. Level 2 represents moderate functional limitation, where children require hand support for sitting but maintain some independent mobility through crawling or assisted movement. Level 3 children need external support for sitting, but demonstrate good head control, suggesting potential for assisted mobility with appropriate equipment. Level 4 classification indicates significant motor limitation, with good head control but limited functional abilities requiring substantial assistance for most motor activities. Level 5 represents the most severe limitation, characterized by poor head control, truncal support, and little to no voluntary movement. This classification system directly correlates with intervention needs and prognosis. Higher levels typically require more intensive therapeutic interventions, adaptive equipment, and long-term support services. The flowchart facilitates consistent classification across healthcare providers and settings, supporting coordinated care planning and realistic goal setting for families. Clinical application requires careful observation of the child's best performance rather than occasional achievements, ensuring classification reflects typical daily functioning rather than optimal momentary capabilities. Functional outcome measures extend beyond traditional developmental assessments to evaluate real-world capabilities that directly impact daily living and quality of life. These assessments become particularly valuable for children with special healthcare needs, where standard developmental measures may not capture functional independence accurately. The Functional Independence Measure for Children addresses activities of daily living, including feeding, dressing, toileting, and mobility skills that determine independence levels. This measure provides objective scoring of functional capabilities, supporting transition planning and intervention goal setting for families and care teams. The Vineland Adaptive Behavior Scale offers comprehensive assessment of adaptive functioning across communication, daily living skills, socialization, and motor domains. This tool evaluates what children actually do in their typical environments rather than their maximum capabilities under optimal conditions. Most functional assessments prove applicable only after 2 years of age, when children have developed sufficient skills for meaningful evaluation. This timing limitation requires careful interpretation of earlier assessments and ongoing monitoring as children mature. These functional measures focus on consequences of diverse medical, behavioral, and cognitive disorders resulting from prematurity, making them ideally suited for planning services for children with special healthcare needs. Evidence demonstrates that children with birth weights less than 750 grams or gestational ages younger than 26 weeks show higher rates of functional limitations, greater compensatory dependence, and increased service needs compared to larger preterm infants. The integration of functional assessment with traditional developmental measures provides comprehensive understanding of each child's capabilities, supporting individualized intervention planning and realistic family expectations for long-term outcomes. Quality of life assessment extends beyond traditional medical metrics to evaluate functional performance in daily activities. These measures focus on the consequences of diverse medical, behavioral, and cognitive disorders resulting from prematurity, providing essential data for service planning in children with special healthcare needs. Assessment tools include the Child Health and Illness Profile for Overall Health Status Evaluation, the QUICCC questionnaire for identifying children with chronic conditions, for identifying children requiring ongoing services, and standardized quality of life measures. the Functional Independence Measure for Children, Vineland Adaptive Behavior Scale, and Battelle assess limitations in activities of daily living, including feeding, dressing, toileting, and communication abilities. Birth weight significantly impacts functional outcomes. Children with birth weights less than 750 grams demonstrate higher rates of functional limitations, greater compensatory dependence, and increased service needs compared to those exceeding 750 grams. These limitations manifest in motor tasks, including manipulating pencils or silverware, pedaling bicycles, and performing routine daily activities. Associations exist between these motor disorders and cognition, behavior, and overall decreased function at school age. Longitudinal studies by Seigel and Associates demonstrate that most adolescents and young adults born preterm report acceptable quality of life despite documented disabilities. These cohorts show similar self-esteem, overall health satisfaction, and quality of life measures compared to normal birth weight controls. Educational and behavioral problems persist into adolescence and young adulthood, yet functional adaptation occurs within existing capabilities. This evidence indicates that while medical assessments document objective limitations, subjective quality of life measures frequently reflect successful adaptation and coping strategies among preterm survivors. Visual complications represent major causes of long-term disability in high-risk infants, necessitating systematic screening protocols throughout childhood. Ophthalmologic testing becomes universally required for all NICU graduates due to elevated risks of retinopathy of prematurity, ROP refractive errors, and amblyopia compared to term infants. ROP screening follows American Academy of Pediatrics guidelines, with examination timing dependent on gestational age and birth weight. Complete retinal vascularization typically occurs by 44 to 48 weeks corrected age, requiring serial examinations until full vascularization is confirmed. The pathophysiology involves abnormal retinal blood vessel development in premature infants, with oxygen exposure and other factors disrupting normal angiogenesis. Post or op surveillance extends well beyond initial screening, addressing long-term sequelae, including refractive abnormalities and amblyopia. The established timeline includes examinations at 6 months corrected age, 12 months corrected age, 2 to 3 years, prior to school entry during grade school years, and adolescence when rapid ocular growth occurs. This extended follow-up addresses the ongoing vulnerability of formerly premature children to vision problems. Even infants without severe ROP remain at increased risk for myopia, astigmatism, and amblyopia. Early detection enables timely intervention with corrective lenses or amblyopia therapy, preventing permanent visual impairment that could significantly impact educational achievement and developmental progress. Hearing loss prevalence exceeds general population rates among NICU graduates, requiring structured screening and surveillance protocols. Pre-discharge universal hearing screening uses otoacoustic emissions, OAE testing, where a sensitive microphone within an ear probe records sounds produced by outer hair cells responding to auditory stimuli. Normal cochlear function generates detectable echoes, while hearing loss prevents echo production. The Joint Committee on Infant Hearing specifies that NICU infants requiring more than 5 days of care should receive automated auditory brainstem response, AABR screening, rather than OAE alone, due to increased neural hearing loss risk. AABR uses surface electrodes to record neural activity in the cochlea, auditory nerve, and brainstem pathways, detecting sensor-in-neural, conductive, and neural hearing losses. Follow-up auditory brainstem response testing becomes necessary for failed screens, providing comprehensive diagnostic assessment. Re-examination at 12 to 24 months addresses critical late-onset hearing loss risks from ototoxic medications, including furosemide, gentamicin, and vancomycin commonly used in neonatal intensive care unit care. Cytomegalovirus infection represents another significant cause of progressive hearing loss, with deterioration potentially occurring months after initial normal screening. This delayed onset necessitates ongoing surveillance rather than relying solely on discharge screening. Early detection enables prompt amplification and intervention services, with evidence demonstrating that children receiving services before 6 months achieve language scores comparable to hearing children. Head circumference measurement represents the most critical growth parameter in high-risk infants, serving as a direct indicator of brain volume and growth trajectory. The largest frontal to occipital diameter provides the most accurate measurement, requiring careful technique with firm tape positioning across the occiput and glabella to ensure reproducibility across multiple examiners. Normal head growth follows predictable patterns, with increases of 0.7 centimeters per week during the critical early months. Accelerated growth exceeding 1.2 centimeters per week raises immediate concern for ventricular dilatation, particularly in infants with intraventricular hemorrhage history. This threshold triggers urgent neuroimaging to distinguish pathologic hydrocephalus from normal catch-up growth patterns. The temporal window for brain catch-up growth proves remarkably narrow and non-renewable. Research demonstrates that catch-up of head circumference occurs exclusively during the first 6 to 12 months after expected delivery date. This critical period represents the final opportunity for normalization of brain growth trajectories, making aggressive nutritional support and complication management essential during these months. Brain growth failure correlates directly with cognitive functioning and manifests as measurable changes on MRI evaluation. Studies document that infants with very low birth weight who remain small for gestational age demonstrate persistent subnormal head growth, with up to 25% maintaining subnormal head size at 2 to 3 years that persists through school age. These growth patterns predict neurodevelopmental outcomes more reliably than many other early indicators. Chronic lung disease is the most common long-term complication requiring intensive management after discharge. Infants with bronchopulmonary dysplasia, defined as ongoing oxygen requirement, at 36 weeks post-conceptual age, often continue home oxygen therapy with intermittent pulse oximetry monitoring because of the risk of right heart failure and other cardiopulmonary complications. Pharmacologic management frequently includes diuretics and bronchodilators, both of which demand careful monitoring. Furosemide increases urinary calcium excretion and can lead to nephrocalcinosis, making substitution with spironolactone or chlorothiazide necessary in some cases. Infants receiving diuretic therapy require periodic electrolyte evaluation to prevent dangerous imbalances that may impair cardiac or renal function. Central nervous system complications, such as post-hemorrhagic hydrocephalus, periventricular leukomalacia, and porencephaly, place these infants at the highest risk for ongoing neurodevelopmental impairment. Those with ventriculoperitoneal shunts need close surveillance for malfunction, which may present with lethargy, irritability, apnea, vomiting, seizures, or a rapidly enlarging head circumference. Nutritional demands exceed those of healthy infants. Baseline needs are approximately 110 to 130 kilocalories per kilogram per day, with catch-up growth often requiring 150 or more kilocalories per kilogram per day. Infants with chronic lung disease require even higher caloric density because of the increased work of breathing combined with fluid restrictions. Prophylaxis with respiratory syncytial virus immunoglobulin is essential for infants born before 32 weeks of gestation who also have bronchopulmonary dysplasia, since they are highly vulnerable to severe viral infections that often lead to rehospitalization and worsening respiratory status. Severe disability criteria at 2 years provides standardized benchmarks for identifying children requiring intensive long-term support services. These evidence-based criteria guide resource allocation and intervention planning while establishing consistent classification across healthcare systems and research studies. Neuromotor dysfunction represents the most visible manifestation of severe disability. Children unable to sit independently, use hands for feeding, or control head movement demonstrate profound motor impairment requiring comprehensive assistive technology and caregiver support. These motor limitations predict ongoing challenges with activities of daily living and educational participation. Sensory impairments carry permanent implications for development and learning. Hearing impairment despite appropriate amplification and visual function, limited to light perception, only creates substantial barriers to communication development and environmental interaction. These deficits require specialized educational approaches and adaptive technologies throughout childhood. Communication limitations, including inability to comprehend or produce more than 5 recognizable sounds, predict significant challenges with social interaction and academic achievement. Medical dependencies, including continuous oxygen therapy, mechanical ventilation, tube feeding, or parenteral nutrition, indicate complex ongoing healthcare needs requiring specialized medical management. Growth failure, exceeding 3 standard deviations below age norms, signals severe physiologic compromise affecting multiple organ systems. This degree of growth failure correlates with cognitive impairment and increased mortality risk, necessitating aggressive nutritional intervention and medical monitoring to optimize developmental outcomes. Early referral to intervention is critical for language outcomes in children with hearing loss. The landmark Colorado study demonstrated that children who received services before 6 months of age achieved spoken, signed, or total communication language scores comparable to hearing peers by 3 years of age. This shifted clinical practice toward much earlier identification and intervention. Further analysis highlighted timing within that critical window. Infants enrolled by 3 months of age showed significantly higher scores for vocabulary comprehension, word production, and both early and later gesture development compared to those enrolled after 3 months. These differences persisted into the second year of life, confirming durable benefit from the earliest possible enrollment. Guidelines from the Joint Committee on Infant Hearing emphasize that all infants with hearing loss, whether unilateral or bilateral, slight or profound, must be referred to early intervention services at diagnosis, and services must begin no later than 6 months of age. This includes auditory neuropathy and progressive or fluctuating losses that might otherwise be underestimated but still carry risk for delayed language development. Effective programs require providers with specific expertise in pediatric hearing loss, including educators of the deaf, speech-language pathologists, and audiologists. The 2013 supplement further stresses an evidence-based framework that is family-centered, culturally responsive, and individualized to the child's degree and type of hearing loss, as well as the family's preferred communication approach. Successful transition from NICU to home requires comprehensive coordination addressing complex medical needs. Initial assessment centers on home adaptation capabilities, including medication management, oxygen therapy, and specialized formula preparation. Children with chronic lung disease require home oxygen with intermittent pulse oximetry monitoring due to cardiopulmonary complications risk, including cor pulmonale. Those receiving diuretics need periodic electrolyte monitoring, with furosemide potentially discontinued if nephrocalcinosis develops. Medical home establishment involves coordinated care between NICU providers and community pediatricians, creating continuity that reassures families while maintaining specialized oversight. Resource coordination encompasses home nursing services, medical equipment provision, and early intervention services. Immunoglobulin therapy prevents respiratory syncytial virus infection in infants less than 32 weeks with bronchopulmonary dysplasia. The complexity demands multidisciplinary collaboration, ensuring seamless care transitions that address both immediate medical needs and developmental support requirements for optimal community integration. Prognostic communication requires evidence-based timing and balanced messaging. 2 years represents the minimum age for reliable neurodevelopmental assessment, as earlier evaluations are heavily influenced by recovery from medical issues and emphasize motor outcomes over behavioral and language capabilities. By 18 to 24 months, environmental factors become more influential and cognitive processes more evaluable. Population data provides the foundation for realistic projections while emphasizing individual variation. For extremely preterm survivors born 22 to 25 weeks, moderate to severe neurodevelopmental impairment ranges from 22 to 45% at 4 to 8 years. However, individual outcomes vary significantly from population statistics. Effective communication balances realistic expectations with hope and empowerment, acknowledging uncertainty while providing families actionable information. The approach should emphasize that while population data informs our understanding, each child's trajectory remains individual and may differ substantially from general trends, maintaining family engagement in therapeutic interventions. School-age challenges persistently affect preterm survivors with concerning trends. In the Epicure cohort, 57% of extremely preterm children required special educational services at 11 years, demonstrating specific problems in reading and mathematics. Academic achievement scores for reading and mathematics were lower in 2005 than 1997, despite similar mean intelligence scores, accompanied by increased academic problems. Educational and behavioral problems persist into adolescence and adulthood, representing the primary service needs rather than medical care. Most commonly reported problems include emotional difficulties, attention and hyperactivity disorders, and socialization issues. ADHD rates range from 20 to 30% in preterm children versus 5 to 10% in term-born children. These difficulties result from visuomotor problems, learning disabilities, and developmental coordination disorders that occur frequently with decreasing gestational age. The problems appear most related to neuropsychologic and psychiatric domains, including deficits in attention, memory, and behavior, rather than global cognitive impairment. Neurodevelopmental outcomes increasingly serve as benchmarks to determine medical intervention efficacy. Long-term follow-up remains critical for identifying negative intervention effects not obvious in the nursery. The postnatal steroid example demonstrates this importance. Enhanced extubation success revealed severe neurodevelopmental sequelae only through longitudinal tracking. Follow-up retention targets maintain research integrity. 90% for early childhood, 80% for school age, and 70% for young adulthood. Subject loss biases impairment rates as dropout risk increases in larger, less sick babies from lower socioeconomic backgrounds. Multi-center networks enable assessment of low-incidence issues, including the NICHD Neonatal Research Network, 15 centers, Vermont-Oxford Network, over 400 centers, and Canadian Neonatal Network, 17 centers. Long-term tracking identifies unexpected consequences of NICU interventions, ensuring therapies demonstrating immediate positive effects aren't associated with adverse long-term outcomes. Regional data provides more accurate outcome pictures than single-center studies by including all-area births. Environmental modifications during NICU can protect the developing brain by minimizing stress and pain exposure. This neuroprotective approach recognizes the vulnerability of developing neural pathways to environmental insults during critical growth periods. Assessment timing requires serial evaluations accounting for changing developmental capacities. Early evaluations below 1 year emphasize motor outcomes with limited behavioral and language assessment capability. By 18 to 24 months, environmental factors become more influential and cognitive processes more evaluable. The Gross Motor Function Classification System provides essential functional motor assessment in cerebral palsy, defining 5 levels based on self-initiated movement, sitting, walking, and mobility needs. This standardized approach focuses on usual performance in home, school, and community settings rather than maximal capabilities. Comprehensive care integration of neurodevelopmental assessment with long-term follow-up drives optimal outcomes. Success requires coordination between neonatal providers, community pediatricians, and subspecialists, ensuring continuity from NICU discharge through school age and beyond while addressing both medical complications and developmental needs.